Nielsen. Okay. So for those of you who don't know me, or haven't been a part of us before, I'm Maria Markowitz. I'm from the Georgia Cancer Center, and I am part of the hub of our Telederm project. And Dr. Patton and I will be serving as co-facilitators of today's session. So we'd like everyone to put their screens on gallery if you can, so we can see you. And last month we reported that Kenza Mamouni, one of us of the hub, had her little baby girl at the end of October. And so this month we report that Marisol Galvis had her little baby girl, Emily, earlier in November. So we've got lots of babies around here. So I want to welcome Telederm Clinic healthcare providers. There aren't too many of you here today, but we welcome you all. And we have two new clinics, Swainsboro and the Phoebe Family Medicine residents who have recently joined us. We also are saying goodbye to Dr. Sam Whaling from Lee Medical Arts. He's been a very active participant from the beginning, and he's accepted a new position elsewhere, so we wish him well, and we will really miss him as participating in the program. And so welcoming our dermatologists, Dr. Davis, Dr. Rabinovitz, Dr. Buchanan, any residents and medical students out there. And from our hub, we have Brenda Santiano, whom you all know, and I are manning the hub, just the two of us today. Also, please remember to write into the chat your full name, your email address, and your affiliation, the name of your clinic or program, whatever that affiliation is. And there should be an example of that in the chat. Before we go further, I want to bring up a couple of topics. So last time there were some issues with people attending who were unable to access their the CME. And so for people who are new, I want to point out that you first have to register through MCG for the CME or CNE. If Brenda, can you go, I think, back a slide, or the one, this one. So and so I wanted to point out that on the flyer, which is on the right, there are two QR codes. One of them, the bigger one on the right, is for the Zoom link, but in the Navy section on the left is a QR code. And if you go to that QR code, that will take you to the registration, the place where you register for CME. And then once you do that the first time, then at the end of every session, you can just text the code for that session into the number that we give you. So that's just a reminder for anyone out there who needs the reminder. And then the other thing I wanted to bring up is that you probably received an email a couple weeks ago from Project ECHO with a request to register to iEcho. So Project ECHO, which we are a part of, is moving to a new digital platform. And so in the future, it will mean that you will get notifications about our sessions through iEcho, not, well, we've been doing it ourselves up till now, and we will continue to do it ourselves for a few months until everyone gets used to this new system. But you have to register for that. And that again is a one-time thing that you'll, and so there's a QR code up here, and in the reminder notice that Brenda sent out this morning for today's session, she wrote the instructions of the link and the instructions of how to register for into the iEcho platform. And then once you are registered, exactly a half hour before the session starts, you will get a reminder notice and about the day's session, and you can join the session right from that reminder email. You can either click on a button that says join through Zoom, or you can click on another button that says join through iEcho. I think you'll want to join through Zoom. It's fewer clicks. And it's going to take getting used to, I know, but one of the advantages of using the iEcho platform is that you will have access to Echo sessions from all other Project Echoes, so that you can scroll through and if you want to attend a session about any other topic, you can do that. So there is going to be a learning curve, but hopefully in the end it will work out better, and we'll see how it goes. Okay, so now let's quickly go through today's agenda. The next slide. So doing our introduction, Dr. Lauren Prusinski Furnung will present the didactic session. Sarah Atari, a medical student, will present a case presentation, and then we'll wrap up and do announcements. So at this point, I can introduce Dr. Doug Patton, who most everybody knows. Doug is the Dean of the Southwest Georgia Regional Campus for Medical College of Georgia, and he spent most of his career as a rural physician. So I will now turn things over to Doug, and he's going to just really breeze through some of our announcements because we're getting a late start.
Thank you, Rhea. We will move quickly. I'm delighted to have us here. I'm delighted to have someone like Mackenzie Maloney serving her clerkship in surgery over in my home base, which is Cordele, Georgia, where I had the pleasure of practicing some of that practice you were talking about. But moving along, we see that this is just a reminder that ECHO is about moving knowledge instead of people, and what ECHO stands for. Next slide, please. Just a reminder that this is about improving knowledge, and we're doing our best to address dermatologic health disparities faced by people living in rural areas and challenges faced by rural providers. Next slide. So these sessions are recorded, as we previously noted, and you're consenting to that by participating. Please don't mention PHI in the discussions. These are not secure for those purposes. And they're not consultations. This is education only. Of course, you can always email us if you have questions at teledermatology@augusta.edu. Next slide, please. We do collect all sorts of data for all sorts of really good reasons. Next slide, please. Next slide. There we go. And just general Zoom reminders. Keep your cameras on if you can, so that we can see your bright and smiling faces if possible. We understand that you might need to turn it off for any number of good reasons, but there are ways to ask questions. You can type them into the chat. You can raise your electronic hand. We'll try and keep up with who's got their hands up. And we'll try as best we can to defer question and answer until we get to the end of each of the separate presentations. Again, you can chat or email with Mahana at msharara@augusta.edu if you have questions, or again, just put them in the chat. Next slide, please. All right, so at this point, it's my pleasure to turn this presentation over to Dr. Lauren Przezinski-Furnon, who's a fourth-year resident in the MCG dermatology program. She also is a beneficiary of some basic clerkship educational experiences here in the southwest part of the state. And with that, I'm going to turn it over to you, Dr. Przezinski-Furnon.
Thank y'all so much for having me today. All right. Everybody hear and see this okay?
Yes, we can. Thank you.
All right, so just wanted to go through some common causes of the quote unquote red leg. So a lot has to do with infection. Some etiologies are related to vasculitis. Super common that we see in clinic, I'd say almost on a daily basis, includes stasis dermatitis, as well as a consideration for contact dermatitis, and less commonly, but we still see it as erythema nodosum. So first off, just to talk about one of the more common entities, so cellulitis. When we're on consults, we do get consulted for this sometimes. So just briefly kind of reminding folks of what cellulitis truly is. So it's a common bacterial infection of the deep dermis as well as the subcutaneous tissues. Most commonly, pathogens implicated in immunocompetent adults include Staph aureus as well as Strep pyogenes. If we're worried about more immunocompromised adults, you'd still consider those same pathogens, but would also consider gram-negative pathogens here as well. In diabetic patients, especially with those with foot infections or ulcers, may be implicated gram-positive cocci as well as gram-negative aerobes and anaerobes. So always want to consider this in the context of the patient. And then certainly aquatic injuries and exposures, we might see that down in our part of the United States, and typically related to Vibrio, Eromonas, or Marinum species. So something to consider. So in terms of what one would see on physical exam, these are more the classic findings of erythema, pain, warmth, and swelling. Most of the time, this is going to be unilateral. I can tell you many times we've been consulted for bilateral cellulitis, and that's highly unlikely. And then in more severe cases, you may see vesicles, bullae, ecchymoses, as well as petechiae. And then also want to be on the lookout for red streaking, which can be indicative of lymphangitis, and these patients may have palpable lymph nodes as well. In terms of management, really the first go-to is empiric antibiotic coverage. Again, kind of looking at the patient and considering their immune status, if they have risk factors for MRSA, and then the presence or absence of purulence. For the most part, most patients are going to be adequately covered antibiotics-wise if you're covering for MSSA and strep with cephalexin or it's something from the penicillins class. And certainly, again, need to consider IV versus PO depending on the patient, the individual patient. So I included the ALT 70 score that we often use, and I know the emergency department uses a lot, basically highlighting the ALT being for asymmetric, leukocytosis, tachycardia, and then age 70 or greater, and using this scoring system kind of to aid in, helping determine whether it's true cellulitis and whether it needs treatment with antibiotics. So moving on to something more serious, even so, necrotizing fasciitis. Thankfully, this isn't something that I've seen in clinic, but have been asked about while on consults. So neck fash, this is a deep infection, most commonly pathogens for type 1 neck fash, which is more so polymicrobial. This can be a mix of aerobes and anaerobes. And immunocompromised patients more commonly seen, such as the diabetic patients or elderly as well. Type 2 is more monomicrobial, most commonly implicated is Strep pyogenes. Risk factors here, certainly want to consider this with penetrating and non-penetrating trauma, any sort of breaks in the skin, other breaches to the skin that may result from other insults. And then in terms of the physical exam, early on, these can be tricky in that it may look like cellulitis with that kind of ill-defined erythema or edema. But one of the key components is noting rapid spread despite initiating antibiotic therapy. And it's, as we've all learned, the quote unquote pain out of proportion to what one is visualizing on exam. They may have bullae, and then ultimately skin necrosis, or they may have preceding ecchymoses as well. And as we know, there's gas in the soft tissue, as well as signs of systemic toxicity, especially as the disease progresses. In terms of management, the sooner the better. This is an emergency. These patients should be started on empiric antibiotics, IV antibiotics. So the different combinations here, either vanc or linezolid plus piperacillin tazobactam, or a carbapenem, or ceftriaxone and metronidazole, just to, again, kind of start therapy. And then certainly want to be in touch with our surgery colleagues for debridement. These patients need ICU supportive care as well as high quality wound care. And evidence shows that, the avoidance of NSAIDs and that NSAIDs can make this worse. Okay, moving on to leukocytoclastic vasculitis. This is something, again, we see somewhat on a regular basis. So these are most commonly palpable purpura as a result of inflammation of the small cutaneous vessels. So basically, inflammation of the vessels leads to vessel wall destruction and leads to the extravasation of red blood cells, which is what causes petechiae and purpura. So there are we distinguish primary versus secondary causes. About 50% of cases are truly idiopathic, and we never quite know this, the true cause. But we often see medications are implicated, different pathogens. Malignancy can be associated, inflammatory bowel disease, as well as connective tissue disease disorders. So on exam, what we most commonly see are these non-blanching round papules that kind of coalesce into patches. They may enlarge and coalesce into these larger nodules and plaques as well. Often see patients with associated necrosis of these areas, as well as bullae and ulcerations at a later stage or more severe stage as well. And our biggest goal is to rule out systemic involvement. So you can have cutaneous limited versus systemic involvement. If there's a concern for systemic involvement, we would want to make sure that patients have appropriate labs like a urinalysis to look at kidney function, basic metabolic panel, CBC, ESRC, as well as consideration of a fecal occult blood test if we're worried about involvement there. And then in terms of management, so again, we kind of distinguish cutaneous limited versus more visceral or systemic involvement. So for the most part, it self-resolves. We really pretty much recommend more supportive care for patients. If there's consideration or concern that there's visceral involvement, systemic corticosteroids, and then the consideration of using anti-inflammatories such as colchicine or dapsone to further mitigate the issue. Can also consider other immunosuppressives, methotrexate, mycophenolate mofetil, azathioprine, or cyclophosphamide. I'd say for our purposes, we're typically recommending in the category of the more anti-inflammatories, especially for someone who has it persistently or recurrently. And then moving on to something much more common that we see is stasis dermatitis. So this is something I will often had been consulted on for bilateral cellulitis, and it turns out to be stasis, which it can get pretty extensive and concerning looking. This is a very common condition affecting the lower legs. It's usually occurring in older adults. So really what happens basically is you have venous dysfunction, which leads to edema and this kind of subacute and chronic eczematous processes that lead to the stasis derm. Risk factors, common ones are obesity, history of congestive heart failure, where you're having fluid overload. These patients are hypervolemic. Deep vein thrombosis is a risk factor as well as a history of a leg fracture or other severe injury to the lower leg, especially. And also note, you may consider this in a patient who has prior surgery within the lower extremity or even pelvic area. And then I think this is probably the most common in addition to what we see in patients with heart failure or just venous hypertension due to, as a result of prolonged standing over a long period of time. In terms of exam, early on, we typically see what I saw presented on the first slide, which was kind of these erythematous, scaly patches and plaques. You may see erosions and crust depending on how edematous and how severe the dermatitis is. You may or may not see lichenification, and they can have significant exudate, again, depending also on the level of edema that they have underlying. Chronically, these patients kind of progress to more what you see on the right with this kind of red and yellow mottling. They might have this brown pigmentation and may or may not have this woody induration. If you've ever examined it, it's quite firm, quite noticeable, and that's quite classic for stasis derm. Management, our first go-to with all these patients, is recommending compression stockings or compression socks. A lot of folks really can start to do even a little bit better without prescription level compression socks. I have a few I recommend on Amazon just because I think they're very helpful for people. And it's hard for a lot of our patients to be able to get them onto the legs. For the actual dermatitis component, we do recommend and often prescribe high potency topical steroids like clobetasol or betamethasone ointments. And again, the main goal is to address underlying comorbidities. So looking at their medication list, looking at their lifestyle, and other medical issues. We certainly look at medications a lot that might be contributing to lower leg edema, such as amlodipine. We know certainly their, cardiology or primary care physician may have a preference, but if we can kind of steer them away from that, we do. Gabapentin is another big contributor to lower leg edema, which obviously is a widely used medication in this patient population. So management further, our goal is also to prevent kind of longer term involvement. So leading to another finding called lipodermatosclerosis. So LDS is actually a paniculitis, so inflammation that leads to fibrosis of the underlying adipose tissue. And you get this quote unquote inverted wine bottle appearance. That's kind of how it's classically described. We're trying to get patients better before it gets to this point. All right, and then another common one is allergic contact dermatitis. So we see this a lot. So as we're all familiar, allergic contact dermatitis is a delayed type 4 hypersensitivity reaction in which patients or people have been exposed and then re-exposed and developed a sensitivity to a certain agent, whether it's topical or systemic. In our cases would be topical. So common agents we see, especially when thinking about the lower legs, urushiol, which is in poison ivy exposure. Nickel is super common. Fragrances, neomycin, especially if we have patients who are treating lower leg wounds, whether it was, an intentional wound like after Mohs surgery, or another procedure versus just a wound that they received out gardening, and then oxybenzone, which is a common component of sunscreen. So things that we think about. And then on exam, usually see erythema, may or may not see vesicles and bullae. Often you will see eroded vesicles and bullae where patients have either scratched at them or they've unintentionally become have eroded, and then may or may not see serous sanguinous or even heme, exudate and crusting. Oftentimes these are going to be well demarcated. So this was actually someone that I saw had been applying some sort of herb under occlusion, under socks that were longer than the socks, obviously, than this person had on, but very well demarcated. You can see a very obvious start and stop. So management, again, really important to review the use of over-the-counter and prescription topicals, especially in these cases, and recommend avoidance of offending agents. For someone like the prior images, we do typically recommend a high potency topical corticosteroid again. You can consider phototherapy if they're unresponsive, and then antihistamines for itch. Finally, one that's less common, but we do see it, is erythema nodosum. These pictures kind of show in different skin types, kind of the subtleties that you may see with EN. So it's the most common type of septal paniculitis due to hypersensitivity reaction. Risk factors include history of infection, pregnancy has been associated, certain medications, especially like sulfa antibiotics, connective tissue disease, as well as underlying malignancy and inflammatory bowel disease. So on exam, may see kind of a mixed morphology. So they may be ill-defined nodules or more obvious, but they are usually pretibial and bilateral. May see background erythema. These may be tender and they do often ulcerate. In terms of management, for most patients, these spontaneously resolve in several weeks' time, and we'll recommend rest and elevation. May need to get not infectious disease, may need to identify certain precipitating factors if it can be identified. And then if it's persistent or recurrent in a patient, can consider use of NSAIDs, colchicine, potassium iodide, and then sometimes use of intralesional triamcinolone to inject the individual nodules. So that is all I have. So thank you very much.
Well, thank you very much. That was a great review. Prompted a lot of questions for me. I'm wondering if we can take a couple of minutes here and see if there are any questions from any of the participants or any of our distinguished faculty. Comments on that?
I'll just point out, I think one sort of important thing about the cases that Dr. Pruszynski-Furnong went over is that you can see like none of these cases did she mention the need for a skin biopsy. So that's one good thing. A lot of these are definitely a clinical diagnosis and really does just kind of speak to some of the importance of the morphology as well as the history, making sure to ask patients about, what topicals they're using, as well as what medications that they're on.
Great point. There was a couple of those lesions. I think it was the second group. It was a little bit of a complicated name. I'm having a senior moment here. I can't recall it, Lauren, but it was the kind of the red patchy lesions.
The vasculitis.
Yeah, it was kind of a vasculitis. And one of the pictures showed it on the soles of the feet. And of course, I'm 3 years older in baseball. And when I was in medical school, we spent a lot of time talking about syphilis. And that reminded me that syphilis is kind of still with us. And sometimes that could be another one of the infectious causes of some of these things, although it's typical on the soles and the palms. Anything else from anyone? At this point, we can certainly continue to monitor the chat. If someone has a question, hopefully Lauren can stick around for a few minutes and answer some questions later. But I do want to keep us moving along. And with that, thank you, Dr. Pruszynski-Furnong, and we'll move on to our case presentation that will be delivered to us today by a fourth-year MCG medical student, Sarah Atari. And so, Sarah, we welcome you today to the program. And at this point, we're going to ask you to share your screen and proceed.
Awesome. Thanks so much. Let me go ahead and get my screen up for everyone. Okay. Can you all see it okay? Okay,
Yes.
great. Well, my name is Sarah Atari. I'm an M3 at MCG, and I'm going to be continuing our discussion of the red leg with the case courtesy of Dr. Buchanan. So a little bit about our patient. She is a 43-year-old female, Fitzpatrick skin type 1. She was initially supposed to be coming in for a psoriasis follow-up and has a history of sun exposure with sunbathing, tanning bed use, and frequent beach and lake trips throughout her childhood and adult life. But actually wanted to come in for a new chief complaint of a new skin lesion. So here are some pictures from April of 2021 when she was initially thought to be coming in for a follow-up of psoriasis that was proven via biopsy that previous February. But she actually came in with this new keratotic red plaque on the right lateral lower extremity. So this new lesion was biopsied and the pathology showed squamous cell carcinoma. And so then moving forward at her next follow-up, it was clinically mostly resolved and she had increased leg swelling. And so the decision was made to just treat with local destruction via EDNC at that time. And then over the next several months to years, she actually ended up coming in with a significant amount of new lesions arising. I'll give you all a moment to look them over, but each of these lesions being pretty characteristically similar, erythematous, hyperkeratotic, some not, papules and plaques, mostly on the lower extremities. So these photographs ranging from 2021 to 2022. And then moving on to this past year in 2023, sorry, it's not letting me, there we go. She continued to have more of these characteristically similar lesions, now with a couple more on the upper extremities and on the hands. So going up to April of 2023. So just to kind of summarize her dermatologic history at a glance here. So these lesions were all biopsied with the pathology results showing squamous cell carcinoma for a majority of them, a couple being SCC in situ, a couple being hypertrophic actinic keratoses, but no basal cell carcinomas. Majority of these lesions being on the lower legs. She had a total of 51 procedures since 2021, so including biopsies, EDNCs, Mohs, fluorouracil treatment, and 15 biopsy-proven skin cancers in just 2 years. So pretty significant. And I'm sure many of y'all are thinking at this point, much like Dr. Buchanan and her team are, what are we missing? Is this all just related to sun exposure and sun damage? Is there some kind of medical condition that we're unaware of, some kind of immunosuppression at play? You know, this is an otherwise seemingly healthy middle-aged woman, no history of HIV, no history of organ transplants or immunosuppressant drugs. And so to answer the question of what are we missing, we need to go back to our history and take a good look. With this being the original history that I presented to all of you, but with the missing factor being that our patient takes hydrochlorothiazide. So a little bit about hydrochlorothiazide in itself. It is known to be a photosensitizing drug. Just to briefly touch on the mechanism, UV light is thought to activate the drug or its metabolites, in turn causing reactive oxygen species, which in turn alter and damage cell membrane and nuclear cytoplasm. So literature has shown an increased risk of hydrochlorothiazide use with non-melanoma skin cancers. Some differing literature on whether it's basal cell and squamous cell, but the majority showing that the increased risk is with squamous cell carcinoma specifically. And the degree of damage is thought to be related to the cumulative dose, with a dose greater than 125,000 milligrams thought to be at an increased risk of skin cancer. So our patient was on a dose of 25 milligrams per day for roughly about 6 years. So a fairly lower dose. She, is a teacher and stands all day and had some lower extremity swelling that she wanted to get treated. So she also notes that she didn't take it every single day. So this max dose isn't even likely the dose that she actually hit. And also just wanted to touch on that the FDA changed the label back in August of 2020, just to mention this increased risk of non-melanoma skin cancers and advise patient and providers to encourage regular skin cancer checks and sun protective, I'm trying to look for the words, sunscreen use and protective clothing, factors. So this is her in October of 2023, so when she was most recently seen. So definitely seeing some improvement in the rash on the lower extremities. No new lesions at this time. She is following up with Dr. Buchanan every 3 months for full body skin exams and spot checks as needed, and then also working with her primary care physician to switch to a non-thiazide medication. So just a couple teaching points. Chronic use of hydrochlorothiazide is known to be associated with an increased risk of skin cancers, as well as hyperpigmentation in darker skin tones. So to, evaluate risk factors before prescribing this medication to specific patient populations, much like this one, people with a lot of exposure to sun and a lot of sun damage history and tanning bed use, to consider an alternative to thiazides in these cases if clinically appropriate. And then some questions for our audience, if y'all don't mind participating. What are appropriate non-thiazide medications to treat high blood pressure and or leg swelling?
Floor is open. Just open your mic or raise your hand and we'll try and look and see. It sounds like a good question for any of our medical students who are on. You can't hide, Kenji.
ACE inhibitor.
Go ahead.
I was just going to say an ACE inhibitor
Yeah.
for her hypertension.
Yeah, there you go. Thanks, Kenji. I was hoping you'd say that one because there's actually a specific article that compared in the US population the risk of skin cancer with people taking hydrochlorothiazide versus ACE inhibitors. And in this population that they looked at, there was an increased risk of squamous cell carcinoma in the hydrochlorothiazide group compared to the ACE inhibitor group for all populations. And then specifically in Caucasian populations, there was an increased risk in both squamous cell and basal cell. So that is a great answer. So our ACEs, our ARBs. And then moving on to our next question, do you recommend any supplements for patients with increased risks of skin cancer?
Any takers?
Yes, I added, or we had talked about adding these in there because our group does routinely recommend, and this patient is currently taking niacinamide 500 milligrams twice daily. And now a lot of times these supplements like polypodium are also available. There's a brand called HelioCare that we'll also recommend to our patients, especially if they have this, increased risk of skin cancers. And in this patient's case, she was getting enough every year to sort of warrant treatment with these or the addition of these supplements.
Asking out of ignorance, are those available over the counter? Do they require prescription?
No, they are available over the counter. Yeah, so the main thing with niacinamide, it also goes by nicotinamide. The one
We lost you there.
thing you want to be careful of is not to get niacin, which can, I was just saying, careful, don't get niacin, make sure you get nicotinamide or niacinamide.
And the reason you don't want to mix those up?
It's because of the risk of flushing with the niacin. We've lost Kendall. People get they're very displeased if you make them flush. So niacinamide, nicotinamide does not have that side effect.
Good. And the niacin is probably ineffective at reducing the skin cancer risk as well. Probably.
Well, no one will take it long enough to find out.
All right. Very good. Anything else, Sarah, would you like to add?
No, that is all I have. These are our references, and thanks for having me. And we can take any questions anyone has.
That's great. Are there any other questions or comments relative to the presentation that Sarah just delivered?
The patients needs to use these supplements like for certain amount of time to consider they are like sun protect, or they always need to use together with sunscreen or any other addition?
I did some research on both of them, and I saw that for niacinamide, there was one study that showed in just 1 year, patients who were on niacinamide versus their placebo had a decreased risk of non-melanoma skin cancer by like 23%, I believe it was. So that effect in just 1 year, I think that's pretty significant. I can't speak to specifically if there's been studies shown with them doing anything supplemental as well, but I think just good sun protective activities in general, like SPF use of greater than 30, reapplying sun protective clothing are always recommended.
Nice. And
Yeah,
do you remember in that papers, or if there's any recommendation to keep using these supplements like for 3 months, 6 months, and then stop, or you just need to keep using all the time?
I can weigh in on that. I think we tell people to use the niacinamide indefinitely. And I have a lot of patients who seem to find who tell me that they have not been cut on nearly as much since they've been taking their niacinamide. There was an article in the New England Journal of Medicine this past year that showed that niacinamide was not helpful in patients who were immunosuppressed. It wasn't felt to have a strong enough effect to help our renal transplant patients who like to grow skin cancers. But the original article touting niacinamide was also in the New England Journal of Medicine. And as Sarah said, I mean, it was a 20% decrease in basal cells and a 30% decrease in squamous cells in that article. And I can also comment on the fern extract supplement, the HeliaCare. That is supposed to be taken 30 minutes before you anticipate going outside. So if you rarely go outside, your patients don't go outside very much, you just tell them to take it 30 minutes before the family reunion that they plan on going to, or before playing golf. But if you have people who really need serious sun protection, then it's to be taken twice a day.
Thank you so much.
Sarah,
Yep.
could you stop sharing your screen?
Yeah, absolutely. Sorry.
Just one other comment is that this individual had numerous skin cancers over a very relatively short period of time. What's a little unusual is that they were frank squamous cell carcinomas. It's not uncommon to have multiple keratoacanthomas, particularly in our older population. And those have a name, they're called eruptive keratoacanthomas. For an individual such as this, the only other recommendation that I would make is to have them wear supportive stockings. I found that very, very helpful for these types of individuals. And actually, for some keratoacanthomas, just compression stockings alone will sometimes make these disappear. Now, that's anecdotal because if you leave keratoacanthomas alone, approximately 40 or 50% will resolve on their own. The other possibility, not for this particular patient, but if you seems like you have the patient under quite good control, is I'm always fascinated with some of the case reports on using Gardasil, the HPV vaccine, for individuals who have unrelentless squamous cell carcinomas. It's something to think about in the future.
Well, that's interesting. I don't even know how to begin to carry that conversation forward. That's way outside my wheelhouse. But thanks for that, Dr. Rabinovich. I'd love to hear from anyone from East Georgia Healthcare Center. We got several locations that are on board. I know that we still see in our older populations a number of patients that are still being managed using hydrochlorothiazide as a part of their hypertension treatment. It's tempting a lot of times to leave someone on that treatment because it's been working for that purpose. But this is an example of how that might not work out. Is there anyone have any experience they would like to share from one of our clinics? Or Dr. Okoro, we see you again joining us from Nigeria. Thank you.
I will say from a dermatology standpoint, I send a lot of my notes back to the primary care physician, suggesting we stop the hydrochlorothiazide, and ask my patients to go back and speak to the primary care physician about possibly stopping the hydrochlorothiazide. I did that just this week already for someone with lupus who doesn't need to be on a photosensitizing medicine, and that's a whole different situation. But hydrochlorothiazide has been our good friend. It's probably a good friend for a lot of people, but again, for people with photosensitizing issues and skin cancers, we tell people we do a lot of tug of war, and those drugs really kind of are pulling things in the wrong direction for some of these folks.
It's been a long time since I've had to deal with the complications of that, but in combination with sulfur drugs in particular, I seem to recall some particularly dangerous and threatening complications from the combination of those drugs. All right. Anything further for Dr. Przezinski-Furnong? Any comments, Dr. Rabinovich, Dr. Davis, about her presentation?
It was excellent.
Well, yeah, well done. And I will say this too about the drugs and lower leg swelling. My big analogy is that we can wrap your legs up in support stockings and you can elevate them. But if the tug of war is that you're on amlodipine and gabapentin, I call that the double whammy. And there is no way in this world we're going to get your leg swelling down. So go back and let's discuss changing the blood pressure medicine. And then also gabapentin, it's dose related. So you maybe don't need it 3 times a day at that high dose. And I would say half the patients tell me, I'll ask them, does it help your neuropathy? No. Well, then maybe we need to talk about that too. But that's a double whammy of leg swelling in my experience.
That's great. So today, I'm just going to kind of wrap it up. We've had a couple of really good discussions that included a lot of things that primary care providers always see, which is complications or at least increased risk from common therapies that we apply or from lifestyles like chronically having to stand up for long periods of time. A lot of careers require that. So I think this is important. I think it was hopefully something that each of us can take back and use. And again, these are opportunities for you to use your dermatoscopes, your molescopes, to capture some of these images, include some of that history, and forward it along for an opinion and some guidance and advice from our excellent dermatological support staff. So let's don't lose sight of that. I thank you all for those presentations. And with that, Ria Beth, I'm going to turn it back over to you.
Okay, thanks, Doug. So certainly this was a great presentation, and I definitely want to thank Dr. Krasinski and Sarah for their presentations, and very, very interesting. I sort of found myself, looking at my legs a lot, but anyway, so for those people wanting CME or CNE credit, the number, the code and text number should be in the chat. And a reminder, just to repeat what I said at the very beginning, for people who are new to us, you must register with MCG for the to get CME credit, and so you have to register one time at the using the little QR code in the navy colored bar on the left. Let's see, our next session is January 8th, and we will be talking about blistering disorders by Dr. Victoria Madre, and have a case presentation by one of our medical students, Hannah Myers. Hannah is participating in another dermatological project with the Cancer Center, which is the Converge project. So so I know Hannah, and she'll be doing the presentation on January 8th. Here are the CME codes and the number. And we did have a number of our Telederm Clinic PCPs come on in the middle of the presentation, and so I want to give a delayed welcome to them, including let's see, Jamie Clark from Swainsboro, one of our newest clinic to join us. And with that, I want to wish everybody a happy holiday, whatever holiday you may be observing in this winter season. So hope you all have time to be with family and friends, and can celebrate whatever you celebrate. So we will see you on January 8th. And also a reminder about if some of you had trouble logging in because of this switching with the Echo platform, remember to look at the email you received today from Brenda, and register and do a profile, whatever you have to do in the for the new iEcho platform. And we will continue with our old way of notifying you, and you'll get notifications from Echo in the new system, and for a few months until we get used to using the new system. Excuse me. So with that, our guests can log off now, and the Telederm Hub team, please stay on for a few minutes. So thank you very much, and we'll see you next year.
That's it.
That's just us? I guess
Yes.
that's just us.
Mhm.
Look at Lou all dressed up.
Sorry, I had an interview today, so I need-
See, okay. So what y'all think?
it was really good.
I think the session went well. I do think we're we're probably gonna need a couple little reminders between now and the next session about the conversion to the iEcho platform.
Yeah,
Actually,
think
once
so.
you get on it, it's easy. I think it's just a matter of helping people understand to look for the emails because it's a different look, it's a different feel, but for me, it was a one click and I was on.
Actually, Brendan, will you have a way of knowing who has registered?
Yes.
Okay,
Mhm.
so maybe after a couple weeks or so, if you can look and see
How many people?
how
is
many
that?
people are registering and
Yeah.
maybe send reminders to our
Mhm.
regular people who, if they haven't registered.
Mhm.
So anyway, I hope it doesn't become a problem for people joining. But I think you're right, Doug, once you're in, then that email that comes out at 3:30 and all you have to do is open that email, which is coming from the Medical College of Georgia, and then click on the Zoom link to join. So hopefully that'll be okay. All right.
I also think the CME link up to the MCG Cloud CME thing, that takes a little bit of adjustment, but once you're in that, I mean, you've got access to everything that's
Yeah.
available through MCG's catalog of CME, and it's archived for quite a while, and so that's pretty valuable for any of the participants.
We had not had in the year and a half we've been doing this, we had not had any problems, but then last month we had 2 or 3 new people and they just could not get it.
Yeah.
They needed assistance, so.
Just some reminders about that. And like I said, I mentioned this, I called the family medicine program director here at Phoebe today just to kind of thank him for getting them on board and getting the devices and all that stuff. And then he was not going to be able to go on. And Tracy and Michael are somewhere in the Mediterranean, so I'm sure that they weren't going to lead the way today to join, but I'll touch base with them before we have another session, so.
But I was pleased that Waynesboro was there, and I think they had a dog with them.
So,
I mean, Jamie was the one
Yeah.
whose name, and then the guy, I mean.
the doctor,
Next to her with the dog, and looked like a cute little dog from what I could see. So that's a new one.
It would also be interesting at some point to look at the YouTube views and just see if we're getting any traction.
Yes, we have. I think I didn't share with our team. We can share that on our next team meeting, but we have some good feedback from our team that track the views on YouTube. It's
Cool.
not up to date because the communication teams try to upload the videos, trying to play with the algorithms on YouTube. So we have until the 14th session there on YouTube, and they are like uploading every certain time.
Okay, good afternoon, everyone. It's 5 o'clock. We'll go ahead and get started. Appreciate everybody being on.
That's me. It's another meeting.
All right, I gotta run, guys.
Okay, all right,
Thank
everyone.
you. Bye,
Can
I-
everybody.
I wanted to make,
Good time.
Rhea,
Thanks.
okay.
Oh, and I guess, we'll have a team meeting next week, aren't we?
Are we?
I don't know if Dr. Davis wanted to say.
Oh, I was just gonna say, we need to really remind the speakers to turn their slides off so we can see each other during the Q&A.
Yeah.
Thank you so much, Dr. Davis. See you.
Yeah.
Thanks, everyone.
Yeah.
Bye-bye.
Okay, bye-bye.
First of all, USB 800,